Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. Welcome you back as I highlight an important paper from the July 2024 edition of the Journal of Rheumatology. Today I have the pleasure of speaking with Dr. Lihi Eder, who's a senior author of our featured article titled Sex-Related Differences in Dispensation of Rheumatic Medications in Older Patients with Inflammatory Arthritis, a population-based study. Lihi, I want to thank you for taking the time to speak to me and the audience on behalf of all the authors of your paper. And with that, we'll discuss the findings of your paper. That's all right.
Thank you.
Okay, so the easiest one, what was the rationale for your study?
Okay, so first I wanted to thank you, Earl, for inviting me to discuss the results of this study. The area of sex and gender, I think, is gaining some interest lately, because we do know that there are significant differences between males and female patients in rheumatic diseases. And there are differences in terms of the way diseases present clinically, the courses of disease, and a response to therapy. With generally, female patients tend to do worse and persist less on advanced therapies. So we also know that early initiation of treatment is cornerstone in the management of both rheumatoid arthritis and psoriatic arthritis, and the delays in initiation of advanced therapies or DMARDs in general are associated with poor patient outcomes and more progression of radiographic damage. So the rationale behind this particular study was to see whether these differences that we see in the presentation and course of diseases between males and females might be explained by differences in initiation of DMARDs across the sexes in both patients with rheumatoid arthritis and patients with psoriatic arthritis. And we also looked at some additional medications that are commonly used in these patient populations, medications that are used to manage pain, like NSAIDs and opioids, partly because pain is a big component, and a big component in the difference between males and females, with generally female patients experiencing more pain. Now, one of the issues in terms of accessing medications, especially expensive medications, is cost. And with this study performed in Ontario, in Canada, we had the opportunity of assessing patients that are covered by publicly funded system, and all patients have similar access to drugs. So that eliminates potential differences between males and females. And I think this was an important aspect of the study.
Thank you. Certainly explains the reason very well. So how'd you do it? How'd you perform the study in more depth?
So as I alluded to, this study was conducted in Ontario, in Canada. We have a public health system, and the study population, including adults above the age of 65. So in Ontario, all of the elderly population is covered by a public insurance. So everyone has similar access to these drugs, and they don't have to pay to use these medications. We also used this system that includes databases, different databases that can be linked to create these cohorts of patients with rheumatoid arthritis and patients with psoriatic arthritis. And so these were cohorts of patients that received the diagnosis of these conditions above the age of 65. Now, the reason we use the age of 65 is because in this particular system in Ontario, we only have access to prescription drugs above this age. And therefore, so the focus of this study is on elderly population. We used the claims database or the billing database, where physicians enter the diagnosis whenever they, depending on the main reason they saw the patient. So the first date that they received the diagnosis of either PSA or rheumatoid arthritis by a rheumatologist was the date of diagnosis. And then the idea was to assess the proportion of patients that received prescriptions for DMARDs, both conventional and advanced therapy, as well as NSAIDs and corticosteroids and opioids during the first 3 years since the diagnosis. We know that the earlier stages of the disease are very important in terms of having an opportunity, that small window of opportunity to change the course of the disease. So we focused on the first 3 years, and we compared prescription of these different categories of medications between male and female patients. We used statistical models, the regression models, to adjust for confounders, that there are some differences such as comorbidities and socioeconomic status, as well as access to rheumatology care that might exist between male and female patients. So these were adjusted for because the focus of the study was differences in males and females, and we looked at these differences in these different categories of prescription and dispensation of these different categories of drugs between males and females.
Approximately how many patients were in each group?
So we had over 13,000 patients with rheumatoid arthritis or early onset and recent onset rheumatoid arthritis, and over 1,000 patients with psoriatic arthritis. There was similar or sex distribution that was similar to what we expect in the general population. So about 70% of the RA population were female patients, and there was slightly higher prevalence of female patients in the PSA population. And in terms of comorbidities, we did find differences, and generally speaking, female patients had a higher or generally more multimorbidity. So if you combine all of the comorbidities that were reported in their medical records, we found a lot more female patients with 10 or more comorbidities. And this has been reported before. It's not a new thing, but it does emphasize some of the challenges that female patients struggle more with, more comorbidities that might influence prescription of medications. And there were also some unique groups of comorbidities like osteoporosis, more common in female patients, and cardiovascular disease more common in male patients. The general summary of the population.
Yeah, a good summary. So now, what did you find?
Okay, so first, we did describe the prescription of medications in this elderly population. As expected, I think we found that corticosteroids were used more commonly in rheumatoid arthritis than in PSA. This is, as expected from the different practices. And there was a gradual decrease in use of corticosteroid since the time of the diagnosis, as we expect the disease is better controlled. Most of the patients were prescribed conventional synthetic DMARDs. So between 70 to 80% of the patients were prescribed these medications during the first 3 years, and slightly more in the RA population and in the PSA population. And this rate of prescription gradually increased over time. Surprising to me, there was a relatively low rate of prescription of advanced therapy. So this included both biologics and targeted synthetic DMARDs, and that the highest proportion was about 10% of the patients, both in the RA group and in the PSA group, prescribed advanced therapies. I expected to see higher rates, but maybe, in this elder population with multiple morbidities and other issues that might influence the decision to initiate these drugs. And then the other important, descriptive parameter is use of opioids that was seen in about 10% of the population. These are lower rates than what we tend to see in the US, for example, where rates of opioid use among rheumatoid arthritis and PSA patients are much higher. In terms of the major findings, I think there were two major findings that I wanted to highlight. One thing is the use of opioids was different between males and females. Female patients were prescribed more or were using more opioid medications, about 50% higher rates of prescription compared to male patients with RA. This was significantly different, and in the PSA population, we saw a similar trend, but because it was a smaller group, this was not statistically different, but still shows that the burden of pain might be higher in female patients, and using these drugs was higher. There was also a slightly higher rate of NSAID use in female patients. In terms of prescription of conventional DMARDs, especially within the 1 year, kind of that initial period after the diagnosis, there were no major differences between males and females across both of the conditions, RA and PSA. But at the 3rd year, there seems to be higher use of advanced therapies in female patients with RA. So over time, more prescription of biologic and targeted synthetic DMARDs in female patients with RA. That was seen at the 3rd year. But as I mentioned, there was generally very low use of these advanced therapies in this patient population.
Okay, I was intrigued by a sub-analysis you did by the sex of the diagnosing specialists. Would you want to go over those findings and the implication, or what you think it means?
Yeah, so I was surprised to see that as well. I think I don't know. I don't know how to explain it, but basically, I maybe describe first what we evaluated whether there was a concordance between sex of the patient and sex of the rheumatologist, and whether this influenced the prescription pattern. We know that mostly in the general community, not necessarily in rheumatology, the sex of the physician could influence prescription or referrals or the way we manage patients. And what we found is that when there was a concordance between the sex of the diagnosing rheumatologist, this tended to influence drug dispensation. When there was concordance, there was a tendency for more intense DMARD therapy. So in other words, male specialists or male rheumatologists tended to prescribe more NSAIDs and less advanced therapies to female patients with RA, and more conventional synthetic DMARD to male patients with PSA. So, I mean, this speaks to potential biases in a way that maybe male or female physician interpret complaints or symptoms or signs in female patients. And I think this may be concerning, that there are differences in the way men and women manage their patients. And this is something that I think we need to acknowledge, that biases are part of the way we do things. And first step in trying to mitigate these biases is acknowledging them.
You mentioned that males physicians, there's a difference. What about with female physicians? Were they just more compassionate to everybody?
I don't know. I think this is the main data. We need to be careful in our conclusions, but
no, not conclusions.
They are. I can tell you that Jessica Widdifield did a study. Jessica Widdifield is a clinical epidemiologist that does a lot of research in the Ontario health data, and she showed that female rheumatologists tend to see less patients than male rheumatologists, which may suggest that they may spend more time with each patient, and that might result in care that is a little bit different than if you spend less time with the patient. Again, I think this is something that needs to be explored in a different way, but it does raise a signal that there might be some ways that it's not all about the patient itself. The physician is also is related to some of these gaps in care potentially.
I guess I didn't quite word my question right. I did come to conclusions that I didn't mean. What I really wanted to know, did female patients treating males treat them in a similar manner as they did females? That was my real question, without a conclusion, without an editorial. How's that?
Yeah, okay.
Okay, so we went over really a little bit of the sex differences that you found in RA, but not PSA. Do you think, I think you implied it may be numbers that show power issue. Is that what you believe in? It might be.
I think that may be one explanation because we had, as I mentioned, 13,000 RA and only 1,000 PSA. And when you try to make differences with small numbers, it's very, I would be caution in terms of drawing firm conclusions, but there are certainly differences in presentation, and PSA is, in my mind, the more complex disease because there are different features and it's more heterogeneous and there are more comorbidities that could influence or confuse us as rheumatologists. So there are studies done by our group and others that again suggested that there are significant gaps in the way PSA present in female patients with more pain and lower quality of life and less persistence on biologic therapies. So certainly these are some of these features might be more severe in PSA. So the fact that we didn't find a difference, I think, I mean, might be related to the lower numbers, I suspect.
You can only look in the future and see what happens.
Yeah.
You answered one of the questions I was going to ask, so we'll move to what do you think the implications for patient care from this study are?
So I think the main take here is the pain, which showed consistency across groups and over time. And especially the higher use of opioids in female patients, this suggests that the burden of pain is higher in female patients with RA and probably also in PSA. And I would argue that opioid use should be minimized to as little as possible in this patient population. And I think we should, as rheumatologists, counsel our patients about better management of pain. And this is emphasized that maybe we should pay more attention to pain, especially in female patients, counseling about pain control using other pharmacological, non-pharmacologic options. Another aspect is osteoarthritis. Secondary OA or primary OA is more common in female patients, and this may require, again, additional screening and counseling, referral to physio, considering referral to joint replacement. We know that there are gaps in access to joint replacement more in female patients than in male patients. So I think all of these aspects around pain, which better management of pain, especially in female patients, might allow us to minimize the use of opioids in this, especially in females.
Thank you. Is there anything you'd like to add that maybe I forgot to ask you or we missed?
I just wanted to say that I'm happy that you selected study to highlight this aspect of sex and gender in rheumatology. I think there are significant gaps, and we continue to investigate the gaps and the mechanisms. And I hope that more journal editors will think that this is a worthy topic to discuss. Thank you.
Well, anytime you have more, please submit. And I want to thank you, Dr. Lihi, Eder, on behalf of all the other authors of their paper, for taking the time to review the paper. It's very interesting findings, particularly around pain and potentially, fascinating to me, the sex of or gender of the physician and the implications. And to our viewers, listeners, please read the complete paper titled Sex-Related Differences in Dispensation of Rheumatic Medications in Older Patients with Inflammatory Arthritis, a population-based study. It is available at the journal's website at jroom.org and has appeared in the July print edition of the journal. I want to thank you all for joining, and I hope you'll come back next month when I speak to the author of an article of particular interest that I selected from the August 2024 edition of the Journal of Rheumatology. And I'd love to hear from your comments on X at jroom or by email at manuscripts@jroom.com. Thank you.